Hello, everyone, and welcome to the Doctors of Running podcast, where we, a group of doctors of physical therapy, discuss the art and the science of the stuff that we're putting on our feet. I'm Andrea Myers, and today we have a very special guest with us, Jeanne Halloran, who is a doctor of physical therapy in Ridgefield, Connecticut. Welcome, Jeanne. It's so great to have you on.
Hi, thank you for having me.
Oh yeah, thanks so much for coming on. I am so excited for this episode. I think we're going to just bring a lot of great information to our listeners. I met Jeanne, a few years ago at a continuing education course, and then we've seen each other at a couple more over the past couple of years. Jeanne is certified in something called Schroth therapy, which is a pretty well-known treatment for scoliosis, although it's well known to PTs, but maybe not so well known to, everyday people. But the way Schroth works, and Jeanne's going to talk about it a lot, it's a curve-specific exercise method for scoliosis. You're also certified in the scientific exercise approach for scoliosis, which you'll talk a little bit more about later. And Jeanne is a PT in Ridgefield, Connecticut at Connecticut Scoliosis and Spine. So anyone local who is dealing with scoliosis, I highly, highly recommend Jeanne and her colleagues over there. Jeanne is also an avid runner, which is awesome. And she's going to tell us a little bit more about her running and the injury that she's currently recovering from. So welcome, Jeanne. Again, thank you so much for joining us. Could you tell our listeners just a little bit about how you became a PT, how you got into Schroth therapy, and then a little bit about your running?
Yeah. So thank you so much for having me. I'm excited to chat with you. Well, I have been running since about 7th grade. I grew up in upstate New York and joined the modified track team and did things like hurdles and triple jump and high jump. And one of the distance coaches just really influenced me. And she actually happened to be my basketball coach for modified basketball. And I realized I just really enjoyed the conditioning part of the basketball program and wasn't really that much interested in the ball. Yes. So by the time I was in, 9th and 10th grade, I joined cross country and, ended up really enjoying the longer distance events. So I did 3,000, in track very often. And then by the time I got to college, I ran Division III up at SUNY Oswego. Nice. And I ran cross country indoor and outdoor. And I did the 10,000 on the track for outdoor. I did the 5,000. Even on indoor, but I would sneak in. I really enjoyed the 3,000 and would sneak in the 1,500. But cross country was definitely my love. I grew up in the Schwangunks in New Paltz, New York, so I got to run on trails and waterfalls, and jumping in creeks and that kind of stuff. So
it's so gorgeous there.
Yeah, it's not too far from where we are. So Andrea happens to be probably about 5 or 6 miles away from me right now.
We could have done this live, Jeanne.
I know, we could have. So I try to get up there when I can. But just with running, I had a friend on my cross country team. She went to school a year ahead of me for physical therapy, and I when I went to Oswego, I was a biology major and knew that I wanted to continue. So I applied to programs and I ended up going to NYU for PT school.
Awesome.
And tried to run as much as I could while I was in school. So
how
once
much
I left,
running was
I actually But then once I graduated, I was on the Westchester Track Club. I did 3 half Ironman.
Oh my gosh.
I did my first marathon in 2006. Mm-hmm. So I spent a lot of time, running.
That's awesome. You're the perfect person to come on this podcast.
And then, from PT school, I worked in a lot of settings. I worked at the New York City Board of Education. I worked at outpatient ortho down in Westchester, New York. And once I had kids, I ended up moving to Connecticut, and I worked in a really big orthopedic practice. And I saw a lot of post-op and just wasn't, by the time I left there, I wasn't afraid to treat anything because I saw so much. But being there, was kind of like a male, you just end up seeing, a lot of things. And I just knew I wanted something more. I knew there was more to PT. I knew I wanted to spend more time with people and patients. And I ended up, my massage therapist over in Ridgefield knew Gail. So Gail Fennell is my current boss. And I just called her up and I said, I think I want to meet you. And her daughter was leaving for college and I was training for the New York City Marathon. I said, let's meet the Monday after the marathon. So I did the New York City Marathon in 2018 and I met Gail the Monday following, a little sore.
Moving a little slowly.
Said, I walked into a little sore and, slowly walked in there. And I knew I just knew after looking at our website, I knew this was a place for me. We started chatting and I was like, I think my daughter has scoliosis. I'm pretty sure she does. And she's like, wait, we got to get her in. And I'm like, and how old is she? She was 8 years old at the time. And that's pretty young to think that your child has scoliosis. So we got my daughter in with Gail like the next day. And I was signed up for Schroth 2 months later and spent 9 days in New York City, certified, got my first level of certification in New York with Hagit Berdashevsky, who is now a mentor. But I'm loving working with Gail. She is my true mentor, and I have been there ever since. So that was from 2019 until now.
That's awesome. Gail is an amazing therapist, and she was the first one in Connecticut to be Schroth certified, wasn't she?
She was. She got certified in the States. She actually brought Schroth here from Germany. And went to Germany, and so she did. She has the longest running practice in Connecticut and in the United States. One of the longest running scoliosis practices in the United States.
Yeah, you guys have a great practice over in Ridgefield, and really a model for like what PT should be. I really, really love what you guys do, and the people I send over to you love it too. So thank you for taking such good care of my Ridgefield people.
Yeah, no, definitely.
So you're running now. You're coming back from a hamstring tear, right?
I am. So I guess going back to I never had an injury all through college. I didn't miss one meet in high school, college, any race I ever trained for. I never missed from an injury up until about 2019. In 2019, I kind of was honestly dabbling in yoga, which I love. And we can talk about why that maybe had an impact on me personally in a not so great way. But I was training for the Chicago Marathon. My one injury was I was training for the Chicago Marathon in 2017, and my back and my buttock really locked up. And I didn't really understand why. I sort of self-treated, and I had people look at me. But by the time I was working at Gail's, I did notice, and she noticed, that I think I have a little curvature. So my daughter has scoliosis. My husband has scoliosis. And I have a little curvature, which affects my pelvis alignment, which we can definitely get into a little bit more. But I have a little bit of a pelvic shift with some rotation there. And it just kind of wreaked havoc on me for then the next few years. And I think... my pelvis, I was getting a little older and things were getting tighter. And I was relying on my hamstrings to just pull me through my runs instead of getting like a nice open gait. I guess natural what happens when I get older, but I also had this little rotation in there. So I did have a hamstring tear from 2019, one of my tendons, training for the Boilermaker. And it just bothered me for years. I never could get in a nice groove. But last September, I was taking my dog out to Huntington, which is basically exactly in between Andrea and I right at this moment, on a little casual dog run in beat up road shoes. And I hit a rock awkwardly and I went into a full split in the gravel. So listen to whatever Andrea and these guys have to say about putting on trail shoes on trails, because I tore the rest of my hamstrings and my adductor magnus, my big adductor muscle. And I was out on the trails, hobbling and sobbing back to my car with my dog. And honestly, I have to say it was the best thing that ever happened to me, because I have a full repair of all my hamstring tendons, and I have less pain than I did from when I tore it in 2019 training for that Boilermaker. So in hindsight, and I'm doing strengthening in a different way. I'm looking at my pelvis in a different way. So, and that's where I'm at. So I actually am up to, I ran 7.5 miles the other day, but in January I was still on crutches. My surgery was on Halloween, and I walked my first mile in January, and I actually did 7.5 miles. It took a while to build up, but I feel like I'm getting back.
Congratulations on your recovery. It can be such a long road, but now being in July, having that hindsight, like, back in January I was on crutches, but now look what I can do, and you're building up and building up. That must be a really nice feeling to be at this point.
It is. I'm slow, but I will take it, and I think that all the research is showing us that running slow makes us fast, as long as you just be consistent until you're at that point where you can get back on the track. But
exactly. Yes. All right. Well, today's subjective is, has a back issue ever affected your running? And if so, what did you do that helped? So listeners, if you want to shoot us an email, leave a comment on YouTube, comment on Instagram, Facebook, let us know what you've experienced and what has been helpful for you. And I'd like to ask the subjective of Jeanne. So we already touched on that a little bit, but so when you finally figured out that you had a small curvature, what has helped you the most? I'm guessing Schroth therapy, but specifically, what do you do?
Yeah, I mean, we'll talk a little bit more about the specifics of Schroth in a little bit, but what we really look at with Schroth is, where your pelvis is underneath relative to your rib cage. That's just one component of it. So if you ever come to our office, the office is lined with mirrors, and you cannot rely on feel.
Right.
Like, we don't know what we look like. No. So I really rely on, getting myself stable, using mirrors to watch where my pelvis is. So if my pelvis is a little shifted to the right, and maybe a little rotated backwards, because I'll talk about what scoliosis is, and it really is a huge rotational component. My muscles then are not in the alignment that they were intended to work. So, I've had a lot of pelvis, piriformis syndrome type stuff, and the deep hip rotators. I don't typically have IT band issues, but that's something that if you have a bigger pelvic shift. And people that don't necessarily have scoliosis can get these rotations because they sit. They sit in cars, and are we sitting like nice and straight? No, we shouldn't be, but maybe we're not moving around enough when we're sitting, or standing up and sitting down. So if we sit, we can develop these really tight restrictions in a pattern that we hang out in all the time, and it can present like scoliosis. So I can treat a person that doesn't have scoliosis and have to pay attention where the pelvis is, and then you strengthen on top of that once you've maybe managed some of their soft tissue, and use mirrors and do all the strengthening things that we really need to be doing, like lunges and that kind of stuff.
It's so common for people to come in the clinic complaining of like knee pain or ankle pain, and they've been to doctors, they've been to 2 other physical therapists, and no one can figure out why their pain doesn't go away. And it's so obvious that they have a pelvic rotation or some other SI joint issue that nobody has evaluated or addressed. And when you fix that more proximal issue, suddenly that knee or that ankle problem either goes away completely or becomes a lot more manageable, and then you're able to actually get rid of those symptoms.
I mean, 100%. That tends to be the people that walk in our door, if they don't, if they have failed maybe more traditional PT where, they just didn't get the eyes on them. A lot of times we notice maybe it's a 20-year-old runner, and he actually has, I've seen this so many times, he actually has a little rotation and he has a little scoliosis. It wasn't enough. He didn't need a brace. But he needs to pay attention to where his pelvis is and stabilize around it in that manner. So we end up finding it, and finding scoliosis in adults and even kids. I treated a high schooler, no idea he had scoliosis. He was a really awesome cross country runner, and his knee he couldn't get his knee better. Then he started having some back pain, and he had some scoliosis, and I taught him what do you do with your body? How do you have to manage this? So it's really common, common.
For PTs and patients out there, if you're a patient and you go to a PT and the only part of your body they look at is the part that's hurting, That's probably not a thorough enough evaluation. And PTs, just remember regional connectedness. Look at the whole body. Someone coming in with neck pain, look at their pelvis, look at the rest of the spine, because the pelvis can drive a lot of spinal issues further up.
Absolutely.
So I'd like to move into the main segment of our podcast today. So we're talking to Jeanne about two things. One, scoliosis, because she is the expert here. But then also how treating the spine and the pelvis can be helpful for people who don't have scoliosis, and particularly how the spine and the pelvis influence breathing. Breathing is so important for everyone, but especially for athletes, because our ability to perform depends on our ability to bring air in and out of our bodies. So first, I just want Jeanne to talk a little bit about scoliosis, what it is, how it's diagnosed, and then what you do in your clinic to address it.
So, very good. So scoliosis is, a lateral deviation of the spine. It can occur in 1 to 4 places. And there are 4 main curve patterns. But the places that are deviated from the spine can either go right or left, and those places that are the most deviated from the spine are also the most rotated segments. So if you think of scoliosis, if you see an X-ray, if you would only see a 2-dimensional view, but it's 3-dimensional, and the areas that are rotated backwards are the areas that you can see, and that's what, you may see the shift, but you also can see what's called the prominence, and that's the area that you would identify first. So, it is really common. About 2 to 3% of people in the United States have scoliosis, and that brings us to about 6 to 9 million people in the United States. And the identifying scoliosis when you're younger is really important because, you can start to manage it at a younger age. So I feel really lucky that and luck might not be the right word, but I got my daughter in quick, and I can share a little bit more about her experience. But as an 8-year-old, if you have some curvature, the chances of it progressing is going to happen, and that's what the research shows, that if you have a curvature at a young age, and we can talk more about that as well. But and how you identify it. Summer's a great time to identify it. If you're, family members, kids are swimming, you want to look for these shifts. If they bend forward, we do what's called an Adams test, and you can see the prominences. So if you see one side of the spine looks higher, a lot of people think, oh, that person's musculature on that side is a lot more developed. And that may be the case, but if it's a true idiopathic scoliosis, the place that's rotated is you're seeing, the spine in the transverse process on that side. There are other types of and so idiopathic scoliosis is adolescent or juvenile scoliosis. Juvenile is if you're diagnosed under the age of 10. Adolescence is if you're over the age of 10 but under 18. Is idiopathic. So we don't know the reason. There is a lot of research, out there. It's a drive in the scoliosis world, but there really has not been one identifying factor yet. And there are some speculations about different hormones in the body and, how it affects our nervous system. But it is a nervous system issue. So, we describe it as the nervous system's failure of the body to control symmetry in the spine. So, we are managing muscles when we do our Schroth or our exercises, but you're really trying to retrain the nervous system, and teach the person how they can maybe put their body. So when I also talk about it being 3-dimensional, we have the curvature in the spine, the rotations in the spine, but the pelvis is attached to the spine via the sacrum. So we know our vertebrae and our lumbar spine, or our thoracic spine, our lumbar spine come down, and the sacrum is the bottom of the spine, and it has fused segments, and it is encompassed by the pelvis. So the pelvis is also part of the scoliosis. And when I'm looking at somebody with scoliosis, I have them stand. I want to see, does their pelvis shift to the right or to the left? And that's where we want to, it's part of our management process is where that pelvis is. One of the things that scoliosis also does, which I don't think that people know, is it does change the shape of the vertebrae. And I think that's why people think we don't have influence on it. Because, how am I going to change somebody's bones, but with the exercises that are pretty specific to that person's curve, you're changing the load on the spine. As they're growing, you can affect the way that their spine is being loaded. And while they're growing, if they're sitting and standing and exercising in a different way, we are having an effect on where the bones are growing and how they're growing. So that's interesting, but we are mostly affecting their soft tissue. That's how we're managing it. But
right. I think a lot of people either forget or don't know that bone is a dynamic tissue. It responds to load. So especially if you're working with an adolescent, that you have a greater probability of changing how that bone develops by changing the loading.
Yes.
Yeah.
Yes. And so sometimes the bones will often grow a little bit more on the anterior side and cause us to be a little bit straighter in our upper body. And one of the other things that we also see, especially after COVID, is that a lot of kids were living in a very flexed posture. And our position of our lumbar spine, maintaining this lumbar lordosis that we need, that we all need, and if we manage it in kids with scoliosis, we can have a positive effect on the spine stability at the lumbar spine. But certainly that is universal. We need to maintain what's called our lumbar lordosis. So if you don't know what that means is, if we're looking at somebody from the side of their body, you have your pelvis and your buttock, and you want that to be, nice and level, which we can talk about. And then you want your lumbar spine to have an anterior moment where it goes forward towards your belly button instead of living in a really flexed position. And then the thoracic spine is supposed to have a natural kyphosis. And sometimes we think of kyphosis as such a negative thing, like we don't want to become kyphotic. And with runners, it's something that we really have to think about because we get tight. Yeah. But with people with scoliosis, they develop this anterior spinal overgrowth, and they tend to be straighter there, which has a negative effect on their curve for the stability of the thoracic spine. So we are looking at the body in all the directions: rotation, the frontal plane, which is the side shifting that you'd see, and if you look at somebody from the side. And that is something that we should be looking at with everybody too.
Oh, absolutely. So. Yeah. And the curvature, the natural curvature of the spine, what you're talking about, kyphosis in the thoracic spine and lordosis in the lumbar and cervical spines, that actually is a smart design, if you will, because it helps the spine accept more load as compared to if the spine was perfectly straight. So people who have lost their natural curves or have reduced curves actually have decreased load-bearing tolerance in that region of the spine.
And what are we doing? We are loading and impact with our running. So it makes a big difference. And who doesn't know somebody that feels like their spine feels stiff after they run?
Right. Yeah.
Yeah.
So you talked a little bit about, diagnosing in children and adolescents and like what parents can do, especially in the summertime, to notice any prominences in the spine. But how do doctors, let's say you think that your child has scoliosis, what should you do next? Do you go to a PT? Do you go to a doctor?
You would go to your pediatrician, most likely, and ask them for a referral to an orthopedic surgeon or doctor who specializes in pediatrics specifically. We are lucky because we live in an area in the tri-state area that we have a lot of doctors that do specialize just in scoliosis and pediatrics. Yeah. So, but if you're in other parts of the country, you might need to just find a pediatric orthopedic doctor. And you would ask them you would encourage them, and hopefully the doctor would give you an x-ray.
Right.
So you would get a full spine x-ray, and most of the time you can see where the pelvis is, and you would, go from the cervical spine down to the pelvis. And from there we would take measurements. And so I need to see all our patients' x-rays because we take our own measurements. I want to see exactly the areas that we need to work on, and address. And sometimes it's obvious, and somebody will walk in the door and their curve pattern is very very obvious. And sometimes it's not, and if they don't fit into an exact curve pattern. So I need to see the x-ray, and we look at what's called the Cobb angle. And the Cobb angle is, the angle that the curvature is, and you measure that, and you get a number in degrees. So like I said before, you could have one curve, you could have two curves, but you would want to measure that. And that would give you a level of severity, where you're at. So if you have a curve that is under 10 degrees, you're actually not considered to have scoliosis. And sometimes we can have some curvatures in there from specific sports, like maybe volleyball or something like that. And we do develop extra muscle in areas that we're overworking. So those are called functional scolioses. But if you have a curve that's between 10 and 25 degrees, you're considered moderate. If you're under the age of 12 and you haven't grown, we would expect, and boys and girls are different, we would expect to see some progression of that number. And so you wouldn't ignore it. You would, depending on, the severity of the curve, we would have everybody do Schroth or any sort of scoliosis specific exercise program. And then typically what it was is that over the curvature from 25 to 45, you would do Schroth and bracing. But actually what's really changing, especially in this area for the better, is that we are bracing kids at earlier ages with smaller curvatures. So I see kids in braces all the time at 18 degrees because they're 10 years old. They have so much growth to go. And they're seeing huge positive changes in there. And one of the other treatment options, and if the curve is over 45 degrees, you're a candidate for surgery, and that's a really big family decision. And it can be hard, it can be easy, and it shouldn't limit you in what your activities you want to do. And people do great. And sometimes you can't manage curves, or sometimes you do catch them a little late, and that's why we talked about catching them early. Take a peek at kids and their spines, or their shoulders shifted, or their pelvis shifted. If you have an inkling, go to your pediatrician, share it with them, and see what they think.
So are schools still screening kids for scoliosis? I remember being screened in middle school. Yeah, that's good. Yep. What age do they do the screening?
In middle school in the state of Connecticut, and I think they do the girls at 7th grade. And they do the boys, I think, in 8th grade, which to me, I think is a little late. Yeah. So, and it might be 6th grade, but my kids both have done it. And they say, my mom, already told me I had some scoliosis. But, they are. And actually, I one of my patients this week, his mom's a school nurse, and she goes, I just see something going on in my own son, and I think we need to manage it. And she was right. So it is happening, but I see pediatricians miss it all the time. And depending on kids' body types, it can be hidden, and certain curves are just harder to see than others. So I'd say just really show the pediatrician and say, can you just look at this area and tell me what you think? And we don't have x-ray vision, so I encourage the x-ray. Especially if they haven't had exposure to x-rays.
Absolutely. Yeah.
So and there actually is an X-ray called the EOS, and it's low dose radiation. It's digital, because kids with scoliosis actually do need more X-rays than kids that don't. And so now this option is here for us, especially they're becoming more popular.
That's great. Just briefly, because I think when you talk about surgery for scoliosis, people think the worst. Like they think about Harrington rods and, fusing the whole spine. And that's not what they're doing these days. So what is surgery like if you do need, if your curve is severe enough? So they are still fusing, and they do try to fuse the least amount of segments that they think that the child or the person needs. One of the things that has hugely changed, I almost want to say in the last 10 years, is when we were talking about the lordosis, that
and the kyphosis, when they would fuse people earlier on, even adults fusions without scoliosis and they needed it for degenerative changes, they didn't know that you needed to incorporate this lumbar curvature. So if you look at somebody that had a fusion prior to 10, I could be wrong now, it might even be 15 years, they did fuse them straight. That does not happen anymore. They now fuse, they're still using rods, but they fuse them managing the lordosis. So you have this natural pressure reducing, impact reducing curvature built in. And they do it and based on measurements that we take in the pelvis. So everybody has specific pelvic measurements based on their body. So somebody's lordosis might be really much more of a curvature than somebody else's. And that may be healthy for them versus the person, like I don't have a lot of lordosis, but that's because my pelvis doesn't. I have the right amount for my pelvis. So they take all these measurements into consideration now, which they didn't before. There is another type of surgery called tethering that has been in the research, and there it was, we just went to a big conference with the Columbia doctors at Columbia Presbyterian Children's Hospital. Dr. Vitale there is one of the leading surgeons, and the big conversation at that conference was tethering and what are the implications and indications, and they are still working it out. But other types of surgeries are on the horizon, and it just, and those depend on where you are in your growth and the degree of the curves and where the curve is, whether it's in your thoracic spine or your lumbar spine.
That's great that there are more
but activity
for
level will not be changed. I mean, kids can run with fusions, kids can play almost every sport. So, kids are not limited.
Right. Yeah, that's great. And I think that I'm glad you brought that up, because I think a lot of people think once you've had a fusion that, you can't play, you can't run, you can't play contact sports. And really, there are very few limitations after those, once you've healed from those surgeries.
We want to get them stable, just like we want to get somebody stable that doesn't have a fusion. Stability is important. All right, so let's talk about how Schroth works. So let's say someone comes into your clinic, they've got their x-rays, you take your measurements. So how do you figure out what exercises to give them and what might their exercises be like? Yeah. So we first determine, do they have one curve or two or more? And you want to know the location of the primary curve. So is there driver or primary curve in the thoracic spine? If it's in the thoracic spine, it has the ribs. So they often tend to be a little bit more easy to identify because the ribs have prominence to them themselves, and they are part of the scoliosis. And then you want to check to see, is it in the lumbar spine? And then you're checking to see, does the lumbar spine and the pelvis go together, or do they go away from each other? And that's one of our big identifiers of identifying which pattern the person is in. And the areas of the curve that are shifted and deviated from the spine and are rotated in those segments, we want to stabilize the muscles around the area. So we work on the area. So the side of the curve that's deviated is called the convexity, and the other side of the curve is called that the curve is not deviating towards on that same segment is called the concavity. The concavity is an area of collapse. So we want to stabilize those positions, and our exercises are designed to manage those specific places of collapse and rotation, as well as elongating the spine. So I take everybody's height measurement when they walk in the door, sitting and standing, and because the areas of rotation are kind of drawing the spine away from midline, as we elongate you and give you exercises, which I'll get into, to bring the spine more towards center and elongate, you will often get a little bit taller, not just from growth. And so the exercises we do are, we do a lot of work on, if you've heard of wall bars, and they look like a ladder, and they're in our facility, and they're probably the prominent design that you think of when you think of Schroth physical therapy. You see these wall bars. And so we always start everybody with a lot of shoulder stability and getting them to start this elongation process so that the spine isn't so shifted laterally and starts to bring it towards midline. So we do lots of things that everybody can do, and certainly runners because of the impact on our spine. But you are, getting on a pull-up bar and doing some shrugs and some pendulums and just doing some hanging with some shoulder control to elongate. But then those areas of the spine that are shifted laterally and we have that concavity area, we do want to develop muscle around the whole area. So we bring in breathing as a tool. Schroth it came from Germany. Katharina Schroth had scoliosis and she treated herself, and she opened a clinic, and this was in the 1920s. And she had 150 people in there at a time, and developed this breathing program. It was considered orthopedic breathing to reshape the body. So we use breathing as a tool to help us activate muscles. If I were to say, make your ribs move to the side, fill in that area. You can't do that with just, making telling your brain to do that. So we use breathing as a tool. So I would encourage everybody, if you're, listening and you're not driving, put your hands on the side of your ribs and see if you can move them without breathing. You can't. You can as you develop practicing, but you use breathing as a tool. So you take a nice expansive inhale breath to find the muscles that you're trying to activate, there's tons of muscles that are going to be incorporated to it. The muscles that live inside the ribs, the intercostals, all the scapular muscles, the lumbar muscles. You don't have to name them. You just need to move them. So if you take that nice deep breath, you can change the shape of your rib cage. And so when you expand, that expansion process into the ribs gives the spine stability. And that's what the people with scoliosis need, is you need this sense of stability. So we're really specific where we want them to breathe, because the areas that the ribs are shifting towards are the areas of least resistance. So our body will naturally go into those areas and breathe more into those areas. And, it becomes a little cycle. And this also happens with runners. We get tight in our rib cage, and where does our breath go? A lot of times to our neck, a lot of times to our pelvic floor. So we use this thought process and this plan to expand the ribs into areas that we need to help facilitate the muscles to prevent this collapse, bring on stability. And then, they are very specific, the exercises, but they're all designed to teach your body what to do, because it's complex, but it's also strategies to get the most out of the body that you can. So some of our exercises, you're laying on your back. Some of them you're prone kind of in a hands and knees position. Some of them you're on your side. And it's all to get the best plan for your body to encourage this muscle recruitment with the breath.
Right. There's a great saying, and I don't know who it's attributed to, but I tell my patients it all the time. The body knows movements, not muscles. So if you're trying to target a certain area, so like for your example, getting the rib cage to expand in a certain area, you can't just say, expand your right lower your lateral rib cage. It's just not going to happen. But if you cue someone, and I know another Schroth therapist, Carol Ann, and she's shown me some things. So like you might cue someone, expand this, and like cueing them on their rib cage, breathe into here, right? And the brain is so much better at performing a movement rather than thinking about engaging, those particular intercostals and that part of your diaphragm.
Absolutely.
Yeah. So I think that's a great example of that. The body knows movements, not muscles saying.
Absolutely. Yeah. Absolutely. And the body knows what it knows. And that's why mirrors are so important, because you're going to go to the place of least resistance. You're going to go to where the body tended to maybe develop some tightness. So you have to use mirrors, I think, when you work out. And when, obviously you can't when you're running, but what you do outside of running influences your running. So, using mirrors and saying, do I look like I'm straight? I don't look like that I'm straight. I didn't even notice, and so using the mirrors to guide you, if you can see what you're doing. We do a lot of videoing with our patients, and I take a lot of photographs of them because they can't see their spines. We can't see our spines. We're relying on me telling them what it looks like. And so we take pictures, and once they even visualize it and see it, you can make a lot more changes.
Oh, definitely. Yeah. And how many times have you treated a patient who has, say, like a SI joint alignment issue, and now their alignment's better, but they feel really crooked because they got used to being off. So the brain has to relearn what, symmetrical is.
Yeah. So we do rely on mirrors. And then what we do is, after we kind of gotten through our specific exercise plan, the sidelines and the prones and the supine exercises, and we use what's called rice bags. We actually bring in these little wedge type things. They look kind of like cornhole tossers, and you place them in there so people can feel where we want the changes to occur, and it guides them. It's just a guide. And it also is a little bit of a protection so that you're not pushing into the areas that are already deviating. But then once we get through that process, we go into what's called integration, and we integrate it into other regular exercise programs, squatting and sit to standing, and running, jogging in place, standing on balance boards, standing on one foot. You need to be able to do the things that we did in those specific programs, in our specific Schroth program, to teach your body what to do. And then you need to be able to use it more functionally. So,
and it sounds like it would. Is it relatively easy for people to do these exercises at home if, say, they install like a pull-up bar and get some rice bags? Yeah.
Yep. A pull-up bar is huge. You can get the ones that are just in and out of the doorways. They're fantastic. Oftentimes people have playground equipment in their backyard. But every exercise that we give, we try to have a home option. Almost everything is easily done at home. And when you have scoliosis, it doesn't really go away all the way. Even if we're managing it and we've reduced your curve, you still have a shift. I mean, unless you've had a reconstructive surgery, but even then, you still have these tendencies for our bodies to shift. So my goal is for people to have an understanding of what they need to do forever. So they go to college, they're running or not, and their pelvis is a little shifted, they have a plan. And if they pull out their handouts and their little videos and they went through it, they can, and we often have, people come back after college, especially if they're high level athletes, and do tune-ups with us. But you do need that time. I mean, the research shows you need that time, which I can discuss. But you need that time with a trained physical therapist to guide you. It's not effective unless you go through that initial process of learning.
Right, and because the exercises are so specific to your
they're pretty specific. They are specific, and it's complex. And not to say that you couldn't benefit from just doing, some elongation, but to get the satisfaction and the actual changes that you need to make, you do need that more specific.
So you mentioned research, and I would love to know what research has been done on Schroth, and what have they found in terms of, like, if someone comes in with, say, a 25-degree curvature, what is Schroth able to do in terms of changing that curve over the long term?
So good question. Sandra Schreiber and Eric Perrant and their team, they have one of the leading studies, and it's the effects of Schroth exercises added to the standard of care on the quality of life and the muscle endurance in adolescents with idiopathic scoliosis. And it's a blinded, controlled, randomized trial. And it was an award at the SOSWR conference in 2015. And what they found was that after 3 months of Schroth in a group of adolescents between the ages of 10 and 18, and curve patterns between the Cobb angle between 10 and 45 degrees. They found that their back muscle endurance and their endurance to hold their corrections and have endurance in your spine increased by holding by 32 seconds. And the control group without the Schroth were only able to control their muscle endurance in their back by 4.8 seconds. So that's a huge, number on just how you can measure muscle, muscle endurance. And they also have found we do what's called an SRS-22, and it is a patient-reported functional pain, self-image, mental illness satisfaction survey that we give all of our patients, but they did it in the same study, and the questionnaire found very big results with the patients that underwent the 3 months of Schroth specific PT versus the numbers actually went down in kids that didn't do Schroth specific, their qualities. So, and that's just one of the studies. Another study by Kuru and Yandel, and they did more of a study on the 3-dimensional Schroth exercises, another randomized controlled study, and they found that that the programs had to be well planned and individualized Schroth programs supervised. And a home exercise without the supervision for the first 3 months was not actually effective at all in treating in adolescent idiopathic scoliosis. And they did find that curvature is definitely going to progress in adolescence. It's inevitable, but the rate of progression was less with the Schroth exercises. So there's a lot of studies out there very similar, but you do need that plan. You really need the guidance.
Yeah. You can't just go on the internet and find exercises for scoliosis and expect to
You really can't.
Yeah.
I mean, you can do some general habit changing things, and you definitely, in this, we talked a little bit in the beginning, the scientific exercise approach to scoliosis, SEAS out of Italy. I mean, they've done a lot of researches, Negrini and their team, about just being active has an effect on decreasing the severity and the Cobb angle. So kids that are active versus kids that are sedentary have less, in general, a less Cobb angle. So being active is important. Does it have an effect on maybe changing the curve as much? Maybe not, but being an active person and athlete and student has huge benefits.
Yeah, makes sense. Yeah. So if somebody wanted to see a Schroth practitioner and wasn't lucky enough to live here in Connecticut and go see you or one of your excellent colleagues, is there like a database where people can find?
There is, yeah. The BSPTS is the school that I was trained in. It's the Barcelona Scoliosis Physical Therapy School. And they have a database, a PT directory, and it can tell you, you look it up, you pick your state, you'll see my name in Connecticut, and it'll tell you if what level they're certified to. So the old school was 2 levels. They recently just changed their school structure. So there's 3 levels. It's all the same information. They just spread it out differently.
Sure.
And SSOL is a scoliosis and spine online learning. Even though it's under online learning, they do in-person training just like the Barcelona. They have also their own PT directory by state. So, you do want to get somebody that's certified.
Yeah, definitely. And we'll throw those links into the show notes for our listeners if you want to check those out.
Happy about that. Yeah.
All right. So now I want to move on to talking about running with scoliosis, because I think there are a lot of people who think that if you have scoliosis, you can't run, which is not true.
Right.
So can you talk a little bit about, if you're a runner and you have scoliosis, what are some things to consider in terms of exercise, just preventative measures? What do you do with the runners that you see in your clinic?
So I assess everybody's strength, obviously. I watch them run. I watch them walk with or without scoliosis. And what we typically see is, some pelvis weaknesses, whether it's the glute med or the glutes or, some of the abdominal muscles. But if somebody has a scoliosis, a lot of times their pelvis, 3 out of the 4 curve patterns, their pelvis will shift to one way or the other. And with the shift that the curve has given the person, the curve drove the patient to have the shift, you want to strengthen the pelvis. So you would watch them, stand on one foot, which you would probably do with runners that don't have scoliosis, and check their stability there. So you would develop a plan and a program that had them watch what their pelvis was doing. It could be simple exercises such as bridges, but if every time you do your bridge, one hip is going higher than the other or more, you're getting more out of it than what's happening to that other side. You're not getting that activation. So we use a lot of things like dowels to put on their hips to see where they're at as far as while they're doing their exercises, if it's not a Schroth specific exercise, and we gear them up towards exercises that are promoting their curve to be more neutral, as well as maintaining their corrections, such as exercises as hip abduction. But if you're doing a hip abduction exercise, which is bringing that leg out to the side, and your whole spine is shifting while you do it, well, you're probably going into your shift. Mm-hmm. And so you want to manage that. So, you learn how to be in your corrections while you do squats, mm-hmm. So if you're squatting and your one tush is going down and your buttock is sinking, you want to use that mirror. So after doing the Schroth program, I would have them do more of the things that all runners need to be doing, deadlifts, single leg deadlifts and squats and lateral step downs and single leg stance and then hopping on and off the wall bar to get that elongation. And also then, going into where their breathing is at. So, encouraging them to expand into those concavities and into those places to get the most that you can out of your lungs and preventing that collapse so that you're becoming more efficient with your run.
Running is all about efficiency.
It is. Yeah. It is. And we can get into that. But, watching the pelvis is huge. And one of the things that I ask all my patients and clients is, if you are a student and you're running in college or high school, or you work at a job where you're sitting at a desk, we sit more than we probably wish we were. Mm-hmm. We probably wish we were running all day. But if your pelvis is you want to think of it like a bucket. So if your pelvis is dumping backwards, and you'd think that, you'd imagine that water dumping out the back of your pelvis, you're sitting in that real posterior pelvic shift. You don't want to sit like that all day. You just shortened some muscles and elongated others, and you lived there for 30 minutes to 4 hours plus, Right. So thinking about where your pelvis in that sense, not just the side shifting, but the mm-hmm. pelvis. In the same sense, bringing it back to running, if we're feeling tired at the end of a long run and our pelvis shifts and dumps forward and we're not, maintaining that abdominal recruitment, now you're going to lose all this energy and you're going to, your back will get tight. You're probably taking deep breaths into these accessory muscles because now your diaphragm, which we haven't dove into very much today, but we should.
We're getting there.
Diaphragm is positioned in a less advantageous way. Mm-hmm. So you can't recruit this breathing muscle that we have. And we end up using our accessory muscles. I mean, how many runners have tight necks and tight backs, because we're not moving our middle, right. So if you don't move your middle, your ribs, your spine, your cervical spine and your lumbar spine will take the load, and you're just not going to be as efficient. And we certainly want to be efficient.
Yes. We're going to get to the diaphragm. And actually, I think we could have made an entire episode just talking about the respiratory diaphragm, but we'll try to hit on the key points. For runners with scoliosis, though, is there anything that you tend to see with them? is it more common to have pain, let's say, in the knee or the ankle or the hip because of that curvature? And if so, what should those runners do?
So like I said, there's curve patterns that the pelvis shifts. So if your pelvis is shifting to one side, then you could have knee pain on either side. It I don't always see one particular side, but if your pelvis is shifting, your femurs are going with it. Yeah. Your femurs are your bones that are connecting to your knees. So I do see, and I was thinking of that high school runner that I saw, who didn't know he had scoliosis. I mean, patellofemoral, we talk a lot about, in running, patellofemoral issues or IT band issues or greater trochanter bursitis. So if you have this deviation, your tendons and ligaments and muscles are set up to work in a specific alignment. If it's deviated too much, you're going to develop overuse in those areas that are just getting, a strain from not being in that alignment. And it all the way goes down, which could totally be another podcast, all the way down to the foot. Yep. So if your pelvis is shifted, and then, your foot's only strong as what your pelvis can manage. But if you have to check it all out. But if your pelvis is shifted and your knee, you want to watch your knee in the mirror when you're doing some of these exercises that we already discussed. Or you want to, videotape yourself running or have somebody watch you run. If your knee is diving in because your pelvis is shifting, well, you could do quad sets and, some squats till the cows come home. But if you're not bringing your pelvis back underneath your ribs, it's going to come back.
Right. Uh-huh.
So it's just kind of fine tuning those areas that need more strength and support and alignment so that you're not getting the overuse at the tendons. Right. So a knee injury is most of the time either coming from the foot or the pelvis.
Yes. The knee is often the victim of the joints above or below it. Yes.
Yes, exactly. So that's really common in people with scoliosis, but it's also really common in people that don't have scoliosis because it's hard to control our pelvis every moment of every step that we take. Yeah. And that's why strength is important.
Yeah, I think that's a really good general point, and we talk about this very often here at Doctors of Running, but you have to look at proximal control, so the pelvis and the spine. If you've had an Achilles problem for 3 years and nothing you're doing is helping, well, maybe you need to look higher up to see what's going on there. And that should really be the case for every problem a person has. Look at the whole kinetic chain, not just the area that is hurting.
Yeah. So yeah, I would say, it is very similar to everybody else. It's just that you have more, I guess, more of a chance of developing, some of these types. But but like I said, somebody walks in my door, they've seen a lot of PTs, they end up having a little scoliosis, a little curvature, and they didn't know it, and it's been wreaking havoc on them for a while. Yeah. So,
So are there any exercises or interventions that runners or people with scoliosis in general should avoid?
So one of the things that is discussed is the aspect of rotation. So we all need some degree of rotation to be efficient with our running, and you want to take advantage of all that natural rotation. When you have scoliosis, you have too much rotation. So we avoid excessive rotation. We do. If somebody walks in my door and they love yoga, I just try to have them modify the exercises so that they're not hanging out in their extreme rotations for too long. I have to say, so we just avoid, just like the flex postures, we avoid sit-ups. Sit-ups are just not, you're forcing yourself into a flexed position. I do not let my kids, and if they're taking the PE class test and it's one day, as long as they're not in pain, I said one day is not going to, really, damage your spine. But, avoiding overflexion, for the upper curves, we do try to avoid like prolonged extension. If they have a lumbar disc, something, we treat them, with our traditional, lumbar extensive type exercises. But rotation is really, and I'm not sure if I lost you, but you're just a little frozen.
Oh, but am I back now?
You're back.
Oh,
yeah.
good.
But rotation is our big concern because you're already rotated in segments more than you need to be. And even in my experience with not knowing that I had some curvature, I loved yoga and I loved the way rotation felt. I pushed myself. I was, trying to get all that. And actually, I think that's what set me up for some of my personal failures with running was that I ended up rotating so much that I caused these excessive shifts and rotations in my spine. Yeah. So that's just my personal journey. But there are people that do yoga and have scoliosis, and they're not limited and they don't have pain. So it's pretty individualized. I think you're back. Yeah. It's pretty individualized, but that's the sense of just avoiding extreme rotation.
Yeah, great. Thank you for that information.
But I do not tell my kids that are gymnasts if you play your sport. Maybe we modify a few things, but I want them to enjoy their activities.
Right. Yeah. So let's talk a little bit about the importance of spinal mobility and rib mobility for all runners. I think we tend to just focus on our legs and forget about the other half of our body, but the other half is just as important for proper running gait and efficient running pattern. So can just give us a brief overview of what role the spine and the ribs and the pelvis play in running gait. What are they doing in stance and swing phase, and what are some common deviations that we might see in runners?
Yeah. Can you hear me?
Yes.
Okay.
Yeah.
So each vertebrae in our thoracic spine should have about 3 degrees of rotation. We have 12 of them. So you should get about, we should have, around 30 degrees or more rotation in our thoracic spine. And we need that to get ourselves to have that reciprocal pattern. And just like at the pelvis, we need to have that reciprocal motion so that we can open up and expand and get into that lower extremity extension. But our ribs have a lot of movement, and they get often on the back burner. And if we don't have, the ribs connect to the front of the sternum and into the back of the spine in the thoracic spine. And if the ribs don't have good excursion or lateral movement, our lower ribs move sort of like a bucket handle. So we lose that. As we run and as we get older, we get tight in our rib cage. We take a lot of breaths. I mean, we are breathing, significant high amounts and at force. Especially with a faster run or longer runs. And if we're not getting those ribs to laterally deviate, then you're going to push that loss of motion into the cervical spine or the lumbar spine. And if we use our diaphragm, if you think of the diaphragm, it's a dome underneath the rib cage, and it connects into the front of the ribs, into the sides of the ribs, into your back. And I would take another moment and ask everybody, take a nice deep breath. And where does your body move? And if you're not getting some movement into the sides of your ribs, then you're probably not using your diaphragm very efficiently. And if you're not doing that when you're sitting, imagine that you're probably not doing that while you're running. So when, and I think that, going back to yoga that we've learned about belly breathing, it's a little bit oversimplified because you don't want to just push air into the front of your abdomen. You need the ribs to move. So when you take a full inhale, your diaphragm is dropping, you're filling up your lungs, and those ribs need to move outward. And that's one of the things that I think we got back to Schroth is that stability comes from that expansion moment that we have when we inhale. We're using it again as a tool. And so if you can open up those ribs, you get more oxygen to the places, it's not just oxygen, but you're getting more use of other areas in your lungs. You can probably hang out and run longer without compensating and without losing the pelvis. So if we lose that, you may have some extra pressure down into your pelvis. You may have some neck trouble. And if you're not getting the ribs to move laterally, your pelvis, you might get these dumps in your pelvis. And those are one of the patterns that we often see is, the leg that's stabilizing you while you're on your stance phase needs that stable moment of the ribs as well. And the abdominals on the swing phase need to hold that pelvis up. So if you kind of lost that natural pumping system of our diaphragm, your stance phase can't support you. You might, and your abs are not supporting you on your swing phase, you might drop. And that's that, you know, common pattern that we see. Or you might develop more of a crossover pattern because you got to get your foot on the ground quicker because you're not as stable as you can be. So I use expansion and think of it as stability, and finding those areas in the lungs that we can to be more efficient in getting that drop and that lift, which affects us hugely with our viscera and our organs. We rely on that diaphragm as a pump, and if you don't, you know, things break down.
And gosh, we could do a whole segment on how all of the diaphragms in the body interact with each other and the movement of them, but we'll leave that for another time. But I think something people might think about is if the diaphragm pump isn't working correctly, that's going to end up putting abnormal pressure on your pelvic diaphragm. And runners who might experience urinary incontinence when running, jumping, looking at the respiratory diaphragm can actually be quite helpful in addressing those incontinence symptoms.
Huge.
Yeah,
for sure. Yeah.
So that was, I think, the information about just the lateral rib cage expansion is so helpful for people. So that would be a simple thing for them to work on, is to just put their hands on the sides of their rib cage and work on getting that outward expansion instead of just focusing on belly breathing. Let's just very briefly talk a little bit about the sacroiliac joint and its relationship to the spine and lower extremities, because I think that that's another overlooked thing in evaluating runners, but it can be a source of pain at the SI joint. It can be a source of pain elsewhere. So just tell our listeners what the SI joint is and a little bit about what it does and how it influences our gait.
Yeah. As I described earlier, we have our lumbar spine. There's 5 segments, and at the base of it is the sacrum. And the sacrum is encompassed by the pelvis. So where that pelvis meets the sacrum is a horseshoe-shaped, really, there's quite a lot of surface area, more than you'd probably think. You really have to pull out a skeleton and look. But of that joint, the SI joint. And we need the SI joint. You know, there's a lot of speculation that you don't need, you know, we're talking millimeters of movement that we need there. But what often happens is, you know, if we have a shift or we're not as stable with maybe our stance phase, you know, and every time you hit that leg on the ground, your other hip drops. I mean, that SI joint is taking the load, or it's going to freeze up and not take the load to try to become stable. And you lose millimeters of movement, and that, believe it or not, is very painful. So you're just building pressure in an area that doesn't want that much pressure. And it can affect, you know, the way that you activate, you know, the pelvis, the hip muscles, the deeper hip rotator muscles that connect the sacrum to the femur. And they get tight. I mean, who doesn't want to roll out their bottom when they come home from a run? I mean, those muscles are working every step we take. Is that going to fix all your problems? No, but, you know, it gives you some relief. If it becomes quite painful, you may need, you know, somebody to assess your flexion and your extension and what is happening with the sacrum while you're moving, not just when you're static, to see. And that would be a key to knowing, you know, if you're seeing the person that you need to be seeing, is, are they checking you what you look like while you're moving, not just when you're standing there. And so you need those millimeter of movement in that joint, and it can be very uncomfortable if it's not moving effectively, if you don't get those little nice shifts to absorb the load of the run.
Right. Yeah, and because your sacroiliac joint is essentially the other half of your hip joint, if you will, because sacroiliac joint, sacrum and ilium, your ilium is part of your hip joint. If your ilium isn't moving normally, or if it's not positioned correctly, that can affect the alignment of the hip joint, which then can either cause hip issues, cause patellofemoral issues, potentially cause foot or ankle issues. So your SI joint is essentially the thing that connects your spine to your leg. So if it's not doing
Yes.
its job to transmit force, that force is going to go somewhere else and cause problems.
Right. Yeah. When I talk about the pelvis, I mean, the pelvis is the socket to your femur, your hip, your true hip joint. So yeah. And that's what's the essay. Yeah.
So I loved the suggestion about working on lateral rib cage expansion. Are there any other general exercises that runners might do to improve their thoracic mobility?
So going back towards some of the hanging on the wall bar, I mean, if you get that nice length and hang, you can do your shrugs from there and opening it up. This is not a scoliosis exercise, but I do encourage my runners to do some kind of like a thread the needle type exercise where you are on your hands and knees. And a lot of times if you see the exercise being done, you think of your hand. So you're on your hands and knees and you're in your nice alignment. Your knees are underneath your hips. Your hands are underneath your shoulders. Your neck is nice and long. You would slide one of your hands between your knee and your shoulder, between your knee and your hand underneath you to get that rotation. And what I encourage people to do is make your ribs move you. Don't just slide your arm underneath you and sort of hope for the best. You take your nice deep breath, and on your exhale, you use the ribs and the muscles we've been describing, that whole universal core and trunk, to guide your body into that rotation. So, and being on your hands and knees is a nice safe position to work, especially for runners. So I do that thread the needle exercise, but again, I really focus on that rib motion. But really, I incorporate the expansion breathing into everything else that we do. So if you're, doing your hamstring stretches, if you're doing your squats, it's really something that you need to do with other things. There's not that many specific, you're just doing rib breathing exercises. I do a lot of shoulder extension, pulling down when you're laying on your back, and, using rubber bands, sort of, like a lat pull down even you can do, but you're focusing on the inhale and up, exhale and down. So you incorporate inhale with your expansion. Yep. When you're exhaling, you want that stability as well, and you want to engage those anterior ribs, bringing the ribs back inward when you're exhaling. So, and I do it on my slow, long runs, slower, even shorter runs where you're not really focusing on speed. You don't have a workout. You're not in a tempo. That's when you can take those nice expansion breaths and just count out loud, like in 2, 3, 4, out 2, 3, 4, and slowing your breathing down while you're on a slow run.
Yeah. So, and even as a cyclist, one thing that I really worked on was being able to slow down my breathing while I was going hard, like getting out of that like chest breathing pattern and taking slower, deeper breaths, which one makes you feel a little calmer and less like you're over the limit. But two, it actually has physiological benefits in terms of how you feel, your heart rate, just your overall rate of perceived exertion. So
I mean, that could be a whole nother podcast with the moving of the diaphragm and the vagus nerve and our sympathetic nervous system and all of that.
All right, we're making a list, Jeanne. Once a month.
I guess, but getting those ribs to move, get those ribs to move. Don't neglect them. Just incorporate it into your stuff you're already doing. And if you're not doing stuff, do a little bit more.
Right. Yeah. It doesn't have to be a huge thing. Just
truly,
basic.
It's just, you got to acknowledge it. Yeah. So, any other, like we said, we could talk so much longer on so many more topics, but do you think there's anything we haven't touched on that our listeners might benefit from with what we've already discussed today? I don't think so. I mean, I don't think I got into, I think I touched upon, getting that pelvis, thinking of it like a bucket. To me, that's pretty key. Yeah. When you're sitting, when you're running, actually, I would say when you're running, if you notice that your pelvis doesn't feel like it's level, put your hands on your hips and say, oh my gosh, my front of my hips are way my front of my pelvis, those iliums are tilted forward, pull them back under just a little bit, and you're You'll make your breathing more efficient, your pelvis more efficient, the connections from your rib cage. I think one thing that I didn't touch upon is stacking, and it's so important in Schroth, or setup. Stack your rib cage on top of your pelvis, just, a bit more, and think of it while you're on your run. Don't let yourself get and it's not about being like super tight and rigid. Just acknowledge it, bring it back to your, a little bit of your cognition of when you're out there. But if your pelvis is dumping forward and you really feel those front hip bones coming down, you're going to run into trouble. And so just pull that pelvis back a little bit. Don't flex your spine. You're just going to neutral. They talk about it in the movie Prefontaine in kind of a funny way. I won't bring it up, but if you wanted to watch it, that would be, he touches upon it. Just, finding that pelvis underneath you, I think I didn't address enough with,
that's a great tip.
While you're running.
And maybe it would be helpful for people, like, check your pelvis in the first, couple miles of your run once you're warmed up, and then compare that to what you're doing at the end of your run. Because like you said, everybody is going to have a different normal pelvis position. So you're not going to know what that is for you unless you feel it before you get tired. So that might be a good way to check yourself.
I mean, I look at it this way as like, we're willing to take supplements and vitamins and electrolytes and awesome shoe gear. Just pull this into this is just like, it's pretty effective. You can be more efficient with just a little bit of attention.
Right. And it's free. Shoes are much more expensive.
Right.
All right. One last question, Jeanne. What shoes are you running in right now?
Oh, gotcha. So I wear, I wear ultras. I really like the wide toe box, but I'm experimenting. I just bought some Sauconys that I used to wear. And I'm going to go get I wear some Topo, and I don't know which ones they are, but I'm going to go get the ones that you recommended, because I think after
the Cyclone too.
Yes, I think that one's for me, honestly. Nice. So that's my next on the list, but I'm kind of going back and forth between some Topo, some Ultras. I really like the wide toe box for me.
Yeah. Ultra's coming out, I think I read, with a non-zero drop shoe soon, so I'm excited to test that one out. And because I'm coming back from my hamstring repair, I'm just bringing on the mileage. I will probably listen, and pick out a shoe when I'm back towards, gearing up for racing. But I have a whole year ahead of me of just some nice base training and build yourself back up.
Yeah.
Awesome. Well, Jeanne, thank you so much for joining me today. This has been just an awesome episode. I think our listeners will learn a lot. We're going to put in the show notes where you can find Jeanne online. Please leave us a review. You can find us on YouTube, Instagram, Facebook, LinkedIn, anywhere you find your podcasts, Apple, Spotify, Anchor. We really appreciate your reviews. They help us grow as a podcast. So thank you, everyone, for listening. And thanks again, Jeanne.
Yeah, thanks for having me. I hope to maybe run with you someday.
Yes, let's do it. All right. Have a great day, everyone.